So let's talk about acute kidney injury, acute renal failure, however you want to talk about it or call it. So for pre-renal, we've discussed that it's from hypoperfusion. That can be the sepsis or the hypovolemia, which is basically a relative hypovolemia, secondary to third spacing. Other causes, of course, can be dehydration, secondary from nausea, vomiting, anorexia, diarrhea. Basically, you get the decrease in cardiac output. In turn, it causes renal vasoconstriction, especially at the efferent arteriole, which is the exiting arteriole. So, with the abrupt reduction in kidney function, that does lead to some retention of waste products. Those are usually eliminated by the kidneys. You get a decreased renal filtration, you get decreased perfusion equals decreased glomerular filtration rate, which equals decreased urine output. And you'll see an elevation in the serum sodium level, and then a decrease in the urine sodium level. You'll have an increase in your BUN, and usually you have to have 50% failure before your creatinine rises. So the creatinine will go up because it's not getting excreted at that distal tubule. Anything that drops the blood pressure, like congestive heart failure, blood loss, dehydration, sepsis, will lead to the pre-renal AKI. So if a person already had a decreased GFR, then it does increase their risk of acute kidney injury. So as we get older, especially from the age of 40 on up, we start losing our GFR by about 1% per year. So yes, aging is one of those things that just takes a toll on our kidneys. Some chronic illnesses or diseases that can occur that can do that. You're going to see atherosclerosis and hypertension. And the way that the atherosclerosis or chronic hypertension works is it damages that afferent arteriole by causing narrowing. So it's unable to dilate when it's needed in order to increase flow through the GFR. So the afferent arteriole will usually dilate and the efferent or exiting arteriole will constrict. So that increases and slows that blood flow through the Bowman's capsule. See, and your creatinine, your to BUN ratio or BUN to creatinine ratio, however you want to say it, your BUN will be 20 times your creatinine. So for a BUN of 40, I think I got that backwards. I do. For a BUN of 30, you're going to see a creatinine of 2. Maybe I don't have it backwards. So for your intrarenal or intrinsic renal, this is the one that will lead to chronic kidney disease, also known as end-stage renal disease or end-stage kidney disease. This is where you can end up with permanent damage to the renal tubules, and the number one cause is the uncorrected pre-renal acute kidney injury. And that's secondary to a late diagnosis or a late treatment. Can even be unresolved despite early treatment. So what ends up happening is you get that renal tubular ischemia, and this is severe hypotension that lasts for a while. With pre-renal, it can be 45 minutes to an hour of a MAP less than 65 to actually put someone in acute kidney injury, whereas we're talking severe hypotension, like you see with septic shock, and hypovolemia, hemorrhaging, blood loss. And then the nephrotoxins, especially IV contrast, there's multiple IV antibiotics that are nephrotoxic, ingestion of toxic substances, the cooling agent, engine coolant ingestion can cause renal shutdown as well. And then there are some anti-neoplastic drugs that can cause damage to the renal tubules. And this will lead to acute tubular necrosis secondary to that pre-renal failure. The cardinal sign, of course, is the tubular debris and the urinary cast. So the urine's going to turn a murky, muddy color. You're going to see floaties in that. You usually have some phases. So, of course, pre-renal is usually the oliguric stage. And that's just when the urine output is less than 400 up to 500, depending on the text, over 24 hours. And these individuals will also have the azotemia, which is the elevated BUN and creatinine in the blood. Now, if this can be reversed with 10 to 14 days, then the outcomes are a little bit better. But if it's more than 14 days that they haven't managed to get this resolved, then they're going to have increased morbidity or increased risk for being end stage. Like I say, if it doesn't get resolved, it does lead to the chronic kidney disease that requires hemodialysis, peritoneal dialysis, transplant if they are a candidate. Now, when they go into the diuretic phase, then they may start dumping out up to 5 liters of fluid a day, and that's secondary to the osmotic pressure. So the urine is not able to concentrate, and this will usually happen for 1 to 3 weeks, from week after the first week up to 3 weeks after the initial injury, before it goes into the recovery phase, to where their kidneys are trying to do the job they're supposed to. Now, with post-renal, we've kind of already discussed that. It's obstruction or partial obstruction, anything that slows or stops those kidneys from getting rid of the urine from the renal pelvis. You've got downstream issues with the ureters, bladder, or urethra. This will cause some retrograde flow due to the increase in hydrostatic pressure within this system. This in turn does interfere with the glomerular filtration rate. In young, healthier people, I guess before age 40, if you have both kidneys, then you're going to be less affected if this is just a one kidney issue. So you may not even, you won't have a decrease in the actual urinary function, because that one kidney that's not compromised can carry the load. We talked about some of the common causes. Can be prostate cancer, enlarged prostate, neurogenic bladder, obstructed urinary catheter, trauma, extrarenal tumors, cervical cancer, so that renal pelvis reflux impairs the kidney function. So what this will show on the ultrasound will be hydronephrosis, and that basically is kidney dilation. So that kidney is stretched out, increased hydrostatic pressure, tubular blockage. So you have an increase in kidney function decline, and if it is relieved in less than 48 hours, then the patient will have a better outcome. And sometimes they'll have complete recovery of their GFR within 12 weeks. And and then they're less likely to lead to the tubular atrophy and fibrosis. Now, post-renal does account for 10% of the acute kidney injury cases. And again, like I said, if you look at table 47-2, it gives the etiologies for all three and breaks it down for you for easy viewing. And so on the chronic hypertension and the atherosclerosis, it does the narrowing of those intrarenal arterioles, especially the afferent arteriole, and like I say, it can't vasodilate. And then those medications that can interfere with the autoregulatory mechanisms of the kidneys would be those NSAIDs and Toradols. Okay, so let's talk about physiology and anatomy of the renal function. So the purposes of the kidneys are to filter and excrete waste and toxins, regulate fluid, electrolytes, and acid-base balance. Usually there's about 1.2 liters per minute of blood filtered through the kidneys. The functional unit is called a nephron, and each kidney has 1.2 million nephrons. One renal artery to one kidney off of the aorta. So you have two renal arteries if you have two kidneys. Sometimes you don't know you only have one kidney until later in life if you get a test, and that happens sometimes. So in order to regulate flow, like I discussed, it's usually by vasoconstriction or dilation of those afferent arterioles and efferent arterioles in the Bowman's capsule. So that actual glomerulus fibrous or porous membrane will allow plasma to filter through that capsule at about 125 mils per minute, and that's GFR. So women are 80 to 125, where men are 90 to 139, is what I read in one text. So the way that autoregulation works in order to maintain that constant pressure in the Bowman's capsule of about 80 to 180 millimeters mercury. Compensation, of course, is maintained when that renal arterial flow is present. So when someone has hypertension, what happens is that afferent arteriole will vasoconstrict, and that does help prevent that high pressure from actually reaching that glomerulus. And it does, and then when the blood pressure is low, that afferent arteriole will dilate, and that will increase the glomerular flow. Now, usually, again, the efferent arteriole will constrict, and so this opens up the blood flow when the afferent arteriole dilates and slows it through and keeps it there a little bit longer because the efferent arteriole vasoconstricts. So the afferent arteriole has those baroreceptors, so when that blood pressure is low, afferent arteriole works as an endocrine gland within itself, and it releases renin, so it starts that RAS system up. Now, and I mentioned this before in class, but this is just a review. So that aortic arch has the aortic sinus baroreceptors, and that will stimulate that sympathetic nervous system, which in turn triggers the afferent arteriole to vasoconstrict. And then in turn, it will decrease filtration and excretion with reabsorption of sodium and water. So that's when we start going into that pre-renal AKI. So you get a drop in urine output, and you get an increase in vascular volume to help raise that blood pressure. This helps to maintain the cerebral perfusion pressure and cardiac perfusion. So blood gets shunted away from the kidneys And the lungs, which doesn't ever seem right to me, seems like we should have a smarter system. But anyway, shunts it to the brain and the heart. So just remember, hypertension will cause afferent arterial vasodilation, which in turn will cause increased fluid filtration. It will decrease sodium reabsorption and increase excretion of sodium and water, because it wants to get rid of that in order to help lower the blood pressure. So there's some pretty good autoregulatory things that our kidneys do for us. Okay, so etiology, we've already discussed the causes of AKI and the causes of chronic kidney disease. The major ones are poorly controlled diabetes and hypertension. They damage the tubules and change that gradient across the glomerular basement membrane, making it more porous. So for assessment, you're going to assess for their risk factors, anything that would impair the blood flow to the renal arteries or through the glomerulus itself. You're going to look at, are they on any nephrotoxins that can interfere with the autoregulatory methods of the kidneys, that interfere with the RAS system, or nephrotoxins that can do direct damage to the tubules themselves. Looking at urine obstruction, of course, you want to evaluate their I&O. Are they on any diuretics? And then looking at their labs, we're going to look at their serum creatinine, their phosphate. Going to look at their urine for CAS. We're going to look at the fractional excretion of sodium in the urine. Serum creatinine, of course, we discussed, comes from the muscle mass and its metabolism. So more muscle, more creatinine, low muscle, low creatinine. Whereas, just remember that creatinine phosphokinase comes from actual muscle breakdown or injury, damage to real muscle, more so skeletal muscle. So creatinine is excreted, never reabsorbed. Acute kidney injury, you're looking at an increase of serum creatinine of 0.3 milligrams per deciliter, or 50% above their baseline in 24 to 48 hours. So there is a lag behind the actual kidney injury. So if they were in surgery and they had issues with low blood pressure for a couple of hours, then you may not see an elevation in serum creatinine until the next day or the day after. But you're going to see that decrease in urine output. So we really can't stress how much you really need to pay attention to that urine output, especially post-surgical. So, of course, men's serum creatinine is a little bit higher. I think it goes up to 1.2. Some textbooks may have 1.3 for the high end, and then 1.1 for females to 1.2 on the high end for females. So our GFR does decrease by 1% per year after age 40. So we're looking at age as well for risk assessment. And then the GFR is what provides the best assessment of overall kidney function. So remember, just on regular chemistry, it's just looking to see if the GFR is 60 or above. It's not looking at the true GFR. And there are calculators to calculate that based on the BUN and other lab values. So I believe Hippocrates has one of those calculators built in, and it is a free app. Death rates themselves have not changed or improved in the past 30 years from acute kidney injury. There is a biomarker that they can check to diagnose acute kidney injury from the urine, and it is IL-18 cytokine. And then they can also look at the neutrophil gelatinase associated with the lipocalin. So, never seen any of those tests ordered on any patients that I've ever taken care of. So let's talk about some interventions based on evidence-based practice and patient and family-centered care. We want to restore and support the renal blood flow, correct any underlying cause if possible. So if your patient's MAP is low, elevate the foot of that bed, before you go page the physician. Try normal means to get that blood pressure elevated. We only really want to use diuretics for fluid management. We want to be cautious, especially if they're pre-renal. And many times the physicians will order a diuretic. So we really want to make sure that's what the patient needs to get their urine started, and do your good assessment skills. What is the blood pressure? What do their neck veins look like? What do their lungs sound like? So really pay attention to those things. We want to assess for their fluid status before we actually give any IV fluid boluses, because we want to avoid any fluid volume overload. So same assessment, what do their neck veins look like? What do their lungs sound like? What do their tissues look like? And then we want to alleviate any post-renal obstruction. Do they have a mucus plug in their Foley catheter? Is that the reason why it's not draining? Or their suprapubic catheter? So we need to get an order to irrigate that with some sterile saline if we don't already have that order. Some institutions, that may be a nursing measure and not require a physician's order. Kind of like the airway, it is the nurse's job to keep that airway patent. We want to identify to see if they're on any nephrotoxins. If so, we want to hold the physician. We want to hold that dose and then notify the physician so we can obtain additional orders. If it's a medication they absolutely need, then the dose will need to be adjusted. We'll talk about that number 6. We want to avoid any contrast media if possible, especially if their urine output is low or if their mean arterial pressure is less than 70. If they have a history of diabetes, we'll make sure that metformin's been held long enough and that it's not restarted too soon. 48 hours is ideal before and after. If they have any renal disease, we really want to avoid that contrast-induced nephropathy. If they really must have contrast with the radiology study, then we'll make sure they get the mucimist, which is the acetylcysteine. And that helps to vasodilate that kidney bed of arterioles, especially that afferent arteriole. And then sodium bicarb to help treat as well. We want to identify any causes and make sure the source is treated, especially if it's sepsis or infection. We want to use a delicate balance of antibiotics, especially if they are nephrotoxic. The standard dose will be too much and will be even more nephrotoxic. So we'll make sure we get that renal dosing that's based on their glomerular filtration rate, their actual glomerular filtration rate. So if they're less than 60, then you'll know what that is. Or you can, again, use the Hippocrates calculator based on their other lab values. We want to look at renal replacement therapy if they have hyperkalemia, if they have volume overload, if they're having metabolic acidosis that needs to be treated, if they're having uremia. Usually they'll treat if there's any altered mental status going on. Some drugs, we want to, drug overdoses, we want to do hemodialysis for that. So, of course, hemodialysis if they are stable on their blood pressure or if their blood pressure, of course, is normal. Then if they are hypotensive or unstable in their blood pressure, if it's labile, it goes from low to normal and back and forth, then they're probably going to need the continuous renal replacement therapy, also known as SLED. which stands for slow, low-efficiency dialysis, because they can't tolerate having that large amount of volume of blood out of their system for any amount of time. And then, of course, patients that require this, 20% most likely will end up requiring, 20 to 25% may require dialysis for life or long-term status. So we also want to review their medical history to know that they are at risk. So chronic disease, got your heart failure, anemia, chronic lung diseases. Have they had any previous contrast-related allergies? Do they need any pre-procedural hydration before they go if they are at risk of getting the contrast-induced nephropathy? We want to assess their hydration status before they go for any test that might require contrast. And you want to follow any policies or guidelines that are set. So kind of always know what the latest and greatest might be so that you can provide education to physicians sometimes. I know that always makes you feel a little uncomfortable, but you are the patient's advocate, so we want to have the best outcomes for our patients. We're going to monitor our patient-centered volume, so what is correct for this patient and what is their hydration status. So each patient is individualized. We're going to look at their daily weight, we're going to look at their skin turgor, want to look at their urine output and what does the urine look like, and then of course what is their fluid intake. We're going to look at and evaluate for risk of side effects from diuretics and from nephrotoxins. Hopefully, if we're giving those, hopefully the patient will resolve before we have to start worrying about any of those, but unfortunately it doesn't happen. We want to prevent any dehydration, secondary diuretics, so definitely you want to check that map and check for orthostasis before you give any diuretics. Check those fluid, the electrolyte levels, and of course any other labs that may be affected from the diuretics. We want to control any vomiting, so make sure they're getting some medication that is safe and has a renal dosing if need be. We want to control any diarrhea, prevent that. If it's non-infectious diarrhea, then we can give stuff to settle that down. If they have a fever, we want to get the fever down. And of course, we're going to monitor for that increase in serum creatinine. And number 13, which I think should probably number 1, because without providing adequate education and information, rationales to our patient and family, then we're probably not going to get 100% buy-in on all of the previous interventions. So that's just the way I feel. So we want to provide that education, especially for patients that are at risk, patients that actually have AKI. We want to talk to them about how important the labs are, that we really need to get our labs drawn. So, and it can also be with the urine. So maybe they're on a 24-hour urine. They need some extra education to know about that so that we can get accurate results. They need to understand why we have them on strict INO and what we need in order to help us to obtain that. And we're also going to give them good teaching about their medications, anything that we're giving IV, so that we have their complete buy-in for providing them with the best care possible for this situation. And just some quick points on AKI. We want to promote earlier detection. So think about ways as a nurse that you could do that. Maybe some community drives, providing education to the floor nurses. So just kind of thinking about that. We want to provide better management. So if we have educated nurses that are watching for AKI, then we can provide earlier detection, and then of course how to manage these patients if it does go undetected, how to treat them, how to improve their outcomes. So as we know, pre-renal AKI has better outcomes. Out of all three types, 10% of those patients may become end-stage renal disease. And that usually has to do with, of course, advanced age, if they have any underlying comorbidities that worsen the problems like diabetes. And then, of course, they started out with a decreased baseline in their GFR, then they're probably going to have issues. And then if they had severe AKI with some delayed treatment, and usually you're going to see that more so in your older patients in the community setting. So if they live alone, or if they already have an altered mental status secondary to dementia, then the identification takes a little bit longer. Family members may not always know that there's a huge change in that, or they may just think it's normal disease progression. So for chronic kidney disease, it really is all about patient and family-centered care. Education is number one. I can't stress that enough. If patients have rationales, then they're more likely to comply with the needed regimen. So explain to them why they need to weigh daily. That's a good indicator that, they're holding on to fluid. So they want to notify the physician if there's a weight gain of more than 2.2 pounds per day or in 5 pounds over the course of a week. So very important. Measure. Can't stress measurement enough. So dietary. If they're on a dietary restriction, they have to measure and comply to that, because that dictates, that's based on what their kidney function is. If they have very little or no kidney function, then they really must follow those dietary restrictions so that they don't have issues between dialysis days. Intake and output. Their intake is based on their previous day's output. If they only had 300 mils out of urine the day before, then their fluid restriction for the next day is about 800 to 900 mils that day. So measure. And when they're in the hospital, make sure we're measuring how much flush. We want to use minimal flush. We want to use drugs in minimal amount of fluids. So we have to help support what they're already doing, and provide education to other nurses if need be. We want to be sure they know they need to avoid any over-the-counter drugs unless the physician has already pre-approved and given them a specific dosage that they can have per day or per week. We really have to look at home or cultural remedies as well, because the majority of these patients end up being Native American or Hispanic. The next group is African Americans that have chronic kidney disease secondary to hypertension. We want to look at some of the teas, because many of these teas they drink can have issues. Licorice can raise blood pressure. So, I understand that they want to do things that are healthy, but we also have to let them know those can interfere with what the physician is trying to get done for them. And then they do need support. They need to join a support group, whether it be online, in person, or both. Without that support of fellow sufferers, or those that are not suffering but excelling in this disease process, they need to know what works and how to manage their disease and how did they do it to be successful. We need to talk to them about hemodialysis and peritoneal dialysis, whichever one is their treatment for those higher stages of chronic kidney disease. The need to check that for that bruit or the thrill. They're not going to have the stethoscope per se at home, but they need to be checking for that thrill in their AV fistula or graft every day. and notify the physician if it's decreased at all or absent. And then peritoneal dialysis. We want to make sure they keep that catheter sterile, that they don't get any infections. We want to go over the signs and symptoms of peritonitis so that they can get early treatment if that starts to occur. To avoid constipation so they don't have any draining issues or outflow issues with that catheter. Teach them about positioning to improve the outflow. And then, of course, if they're going to be a transplant patient, we want to talk to them about how they get on the list, how they can solicit it for a donor from their family or friends. Just being open and honest. And, sometimes it's not necessarily their fault that their kidneys have failed. It's not necessarily, maybe they didn't know they had hypertension. Maybe they didn't have insurance, and now that they have the Affordable Care Act, and now they have insurance, they got diagnosed with hypertension, and then the doctor found that they also had, all this damage from uncontrolled hypertension for years. You've all been at Bedlam and seen some of these blood pressures on people that, are come in for the acute care clinic, and it's like, how are you still in the upright position? So many times it goes unrecognized if they haven't had continuous health care. So we want to make sure, maybe they were on medications. Maybe they didn't know that they weren't supposed to take, as much ibuprofen as they did every day. Sometimes kidney failure is secondary to treatment of other conditions, chronic conditions like rheumatoid arthritis. Many of these drugs that they're on are very renal toxic, and they were on the normal dose and following all the rules, and their kidneys still got damaged. So it's not always their fault. And even if they weren't managing their disease very well, maybe it was poor education on the healthcare team's side. So I can't stress education anymore. So just kind of knowing what can qualify them for a transplant. What do they need to do? Are they even a candidate? So this question will come up when they realize what's going on. And they're going to look to you as a nurse, because you're the one at the bedside all the time, for information. So just be prepared to provide that when the question arises. Luckily at St. Francis, we have a wonderful transplant team. They will come up. They will talk to them. They'll review their record and see if they're a candidate. Same thing in the outpatient or community setting. Just if they are having questions and you can't answer them, then get them in contact with someone who can, because they may be a candidate and just have not received that information. And we have to consider religious preferences. So some religions or denominations don't believe in transplants or blood transfusions. People, they end up with this chronic kidney disease or chronically anemic, so they may need transfusions. Just kind of keep the spiritual part in mind as well. Be sure and review the transplant PowerPoint that I posted in the course, and the dialysis, of course. I'm not a dialysis nurse, so I don't even want to go into the different types of diacylate, just knowing that the peritoneal is usually high in sugar, so with your diabetic patients, it may affect their blood sugars. It uses the high level of sugar, creates that osmotic effect, so that it helps pull the water into that peritoneal space. I don't recall that there were any diacylate questions on the previous exams that Miss Lamb has given. So whatever's she recommends studying, I would study. And let me know if you have any questions. I just like to make these podcasts available for those that benefit more from hearing and writing notes.